Hi, my name is Shane Kuo. I'm a third-year resident at the University of Miami program at Holy Cross Hospital in Fort Lauderdale, Florida. Today I'm going to talk about my abstract, Impressive Hemorrhagic Pancreatitis in the Setting of HIV Managed Conservatively, written by me and Dr. Medeiros, a second-year resident at the University of Miami at Holy Cross Hospital in Fort Lauderdale, Florida. Now to begin. One of the most common gastrointestinal indications for hospitalization is acute pancreatitis. It is essential for physicians to be aware and recognize the possible complications that may arise when treating pancreatitis, such as pseudocysts, acute respiratory distress syndrome, necrosis, and hemorrhagic pancreatitis. We present a unique case of hemorrhagic pancreatitis defined as bleeding within and around the pancreas, usually seen as a late sequela of acute pancreatitis. We hope to increase awareness of these potential complications and encourage further research into potential treatment options. Our patient is a 34-year-old with a past medical history of recently diagnosed AIDS and recurrent pancreatitis secondary to alcohol use. He presents with abdominal pain associated with vomiting and diarrhea. Of note, the patient was recently admitted due to acute pancreatitis complicated by a pseudocyst just the past month. Upon arrival, the patient appeared uncomfortable with tenderness to abdominal palpation. Labs were notable for a white blood cell count of 15.7, CD4 count of 31, lipase of 4,830, AST 89, ALT 41, and total bilirubin 1.5, and an INR of 2.9. CT abdomen was notable for acute changes of pancreatitis with abdominal ascites with a high density fluid in the subhepatic space concerning for hemorrhagic component. This can be seen in Figure 1. At this time, the patient was started on IV fluids and meropenem. The patient would remain stable but developed recurrent left-sided pleural effusions requiring a chest tube that produced exudative fluid. MRCP performed revealed complex hemorrhagic and non-hemorrhagic fluid collections in the upper abdomen with connection to the pancreatic duct. Due to these findings, CT-guided aspiration and drain placement in the largest accumulation in the right upper quadrant was performed, and the fluid was sent out for cultures that grew Enterococcus facialis. Output was monitored and would decrease as the patient would clinically improve. Surveillance imaging was performed, which showed improvement of the largest collection, but notable peripancreatic fluid stranding and pseudocysts were seen. Gastroenterology recommended a transfer to a facility capable of performing cystogastronomy and necrosectomy with endoscopic ultrasound. However, this was not possible at this time due to social circumstances. The choice was made to be continuing with conservative measures such as antibiotics, monitoring output, and following clinical status. Over the following week, the patient was found to be stable enough to be discharged with education on the importance of alcohol cessation. Hemorrhagic pancreatitis is a rare complication during the course of acute and chronic pancreatitis. Although common, it is considered a rapidly lethal complication of pancreatitis. Therefore, it is important to be aware of the pathogenic factors such as severe inflammation, pseudocyst, necrosis, and inflammation. Our case illustrates how recurrent episodes of pancreatitis induced by alcohol abuse led to predisposing factors of inflammation and multiple pseudocysts, turning into a lethal complication of pancreatitis, which was managed conservatively. Proper education becomes a key factor to prevent further recurrence. We hope our case and its impressive radiographic findings encourage physicians to consider this potential fatal diagnosis. Thank you.